Can you all hear me? Good morning, Ramanathan. So, if you're joining the session, good morning, Alia. So, if you're joining the session for the first time, this is Dr. Shanmugapriya. I'm professor and head of the Department of Biochemistry at Government Thuthukudi Medical College, and I'm your Unacademy educator for Biochemistry. And this is a rapid revision session for FMGE aspirants, and this is a marathon session. Good morning, Mohammad Jafar. So this is a rapid revision session for FMGE aspirants. I'm planning to do it as 2 parts. This is part 1, and part 2 will be between 2 p.m. and 3 p.m. today. So if you watch these 2-hour sessions, you'll be able to revise most of the previous year questions of FMGE. And I have chosen all important topics, starting from vitamins. I know FMGE question paper setters are very in favor of vitamins. So many questions will be discussed related to vitamins, and all applied biochemistry MCQs will be discussed now. And before we start the session, so let me tell you a few facts about Unacademy's plans. So on Unacademy platform, we have something called as Compete, wherein 2 aspirants can compete with each other one-on-one using MCQs. So do try it. It will be a fun way of learning any subject. So that's about Compete. And then if you're a NEET PG aspirant, to boost your NEET PG 2023 preparation, there are multiple batches which are happening. So do enroll yourself for all these sessions. And this is the current NEET PG subscription plan, wherein if you want plus subscription, the minimum that you can opt for is 6 months, and that would cost you 13,770, and the maximum is 2-year subscription, that would cost you 45,900, and this is inclusive of 10% off. And if you want to use an educator's code, you can use my code. My code is C Shanmugapriya. So that's all about Unacademy's plans. Now let's start discussing MCQs. So this is the first question for today. I hope you must have all seen this question. So before we start the session, my request to you all is please try attempting grant tests. And writing grant tests will help you in a great way. Please explain the association of thiamine in alcoholics. Definitely, Mohammad Jafar, there is a question on alcoholism and thiamine deficiency. I will definitely explain that to you. So all of you, please try writing grant tests. You have to be familiar with all previous year questions. So this is a previous year question. A 26-year-old woman presented with neuropsychiatric manifestations and acute abdominal pain. Exploratory laparotomy was done with no findings. She gave history of urine turning dark on standing, dark on exposure to sunlight. There was no photosensitivity. So the key that is provided to you here is there was no photosensitivity, but there is history of acute abdominal pain and neuropsychiatric manifestations. And if you look at all these choices, Alia Khan has answered it as alkaptonuria. Alkaptonuria will never present with neuropsychiatric manifestations or with acute abdominal pain. Alkaptonuria will only present with what? Uchronosis. What is uchronosis? Joints involvement. So this is not alkaptonuria. If you look at all these choices, do you see porphyrias are all choices? Okay. So I want you to know about classification of porphyrias, because generally if it's a case-based MCQ when they give you symptoms and they ask you to make a diagnosis, you should know how to classify porphyrias. So there are 3. This is not phenylketonuria ghost rider. Do you see phenylketonuria among choices? No, right? So this is not phenylketonuria. Had it been phenylketonuria, there should have been a history of mental retardation. There should be a history of mousy odor. and hypopigmentation. Do you all understand this? So what are the features of phenylketonuria? I'm very happy that you're all interactive. Please go ahead, give me answers. I will tell you why that is not the right answer. I will also explain you why that can be the right answer. So why is this not phenylketonuria? First is there will be mental retardation component, hypopigmentation and mousy odor. We don't find any of that here. Okay, and phenylketonuria does not present with urine turning dark on exposure to sunlight. Okay, so porphyrias, what are the three types of porphyrias? So you think Ghost Rider thinks it's acute intermittent porphyria. Very good, Ghost Rider. So acute intermittent porphyria will present only with neuropsychiatric manifestations without photosensitivity. So the moment we think of porphyrias, we think of photosensitivity, but please remember, not all porphyrias present with photosensitivity. So what are the three types of porphyrias? The first type of porphyria presents only with neuropsychiatric manifestations, wherein classically there will be a history of acute abdominal pain. And anticipating some abdominal disorder, imaging studies will be done, even exploratory laparotomy will be done, but nothing will be found out. It is because it is purely, the explanation for this acute abdominal pain is just paresthesia. Do you understand this? Just paresthesia, there is nothing internally happening, and they present with bizarre behavior. So one type of porphyria presents only with neuropsychiatric manifestations. Second class of porphyria would present with only photosensitivity. And the third type of porphyria presents with both neuropsychiatric manifestations and photosensitivity. So I am going to tell you what are the porphyrias which come under the first category. Under the first category, you should include acute intermittent porphyria. So the famous acute intermittent porphyria does not present with photosensitivity. And the second one is ADP. What is ADP? It is ALA dehydratase deficient porphyria. Yeah, what is it? Is ALA dehydratase deficient porphyria. So these two porphyrias present only with neuropsychiatric manifestations without photosensitivity. Now, what are the porphyrias which present with photosensitivity? The most severe porphyria is congenital erythropoietic porphyria. Yeah, the most severe porphyria is congenital erythropoietic porphyria that presents only with photosensitivity. They do not present with neuropsychiatric manifestations. And the second one is the most common porphyria. If they ask you which is the most common porphyria, what will be your answer? Your answer should be Porphyria cutanea tarda. So the term cutanea by itself tells you that it presents only with photosensitivity. And the third one which presents only with photosensitivity is erythropoietic protoporphyria. Very good, Viram. So the third one is erythropoietic protoporphyria. So what are the porphyrias which present with photosensitivity? Congenital erythropoietic porphyria, the most severe. The most common porphyria cutanea tarda and erythropoietic protoporphyria. Now what are the porphyrias which present with both neuropsychiatric manifestations and photosensitivity? This will include hereditary coproporphyria. So how are we going to memorize it? Co means both, right? Co means coexisting. So what is coexisting here? Both neuropsychiatric manifestations and photosensitivity are coexisting. So it is hereditary coproporphyria which presents with both neuropsychiatric manifestations and photosensitivity. The other one is variegate porphyria. Hi Osama Sheikh. The other one is variegate porphyria which also presents with both photosensitivity and neuropsychiatric manifestations. Yeah, so don't you think it's easy to remember this way? So I'm going to tell you, I'm going to repeat this. I want all of you to repeat it along with me. So tell me, what are the three types of porphyrias? Yeah. Yeah, what are the three types of, one second, there is something with Notability app. Very good. The one which presents with neuropsychiatric manifestations, the one which presents with photosensitivity, the one which presents with both. So what are the conditions which present with neuropsychiatric manifestations? That is the most popular one. I won't say that's the most common. The most popular one, which is acute intermittent porphyria, that presents with only neuropsychiatric manifestations. The other one is ALA dehydratase deficient porphyria. And the one, what are the porphyrias which present with photosensitivity? The most severe one is congenital erythropoietic porphyria. The most common porphyria is Porphyria cutanea tarda and erythropoietic protoporphyria. Now, what are the porphyrias which present with both? Both will include hereditary coproporphyria, hereditary coproporphyria, variegate. Variegate means various. So what is various here? That is various manifestations starting from neuropsychiatric manifestations till photosensitivity. Okay, give me a minute. There is something with the app. So we have discussed till this. Let's discuss the next question. So why do you think this is the answer here? Because this is a porphyria case presenting with only neuropsychiatric manifestations and acute abdominal pain. This is the only presentation. But what is not found? There is no photosensitivity, which means it has to be either acute intermittent porphyria or ALA dehydratase deficient porphyria. Very good. So the DNA repair defect that causes xeroderma pigmentosa is, what do you think is the right answer? So DNA repair mechanism you should know thoroughly before you go for your exam. The DNA repair defect that causes xeroderma pigmentosa is, very good Alia Khan, yes, it is nucleotide excision repair. Very good Aishwarya Yadav. So xeroderma has got X and it is X nucleotide excision repair mechanism defect. Okay, so now I am going to tell you few facts about DNA repair mechanisms. Before we start discussing about DNA repair, let's try to understand about defects that can happen in a DNA. So the first fact that you should know is about base excision repair. This is the most common error that can happen in the DNA. So which is the most common error that happens in a DNA? It is base excision error. The second error that you should know about is mismatch error. So what is mismatch error? If there is A on one strand, you expect T to be on the other strand. Instead of you finding T, if there is a G or a C, that is called as mismatch error. That is the next common error. And the third error is pyrimidine dimerization. Yeah, the third one is very good Alia Khan, you're rocking it. Yes. So the third one is pyrimidine dimerization. So when is that pyrimidine dimerization which is happening as an error? Whenever there is UV light. In the presence of UV light, adjacent pyrimidines undergo dimerization. That's a third error. And the last error is double-stranded DNA break. So these are the four errors that can happen in a DNA. So what are the repair mechanisms? So for repair mechanism of mismatch error, if there is a defect that causes hereditary non-polyposis colon cancer. So how do we remember it? Mismatch has got two M's. Yeah, mismatch has got two M's and a defect of mismatch repair causes 2C. What is 2C here? Hereditary non-polyposis colon cancer. Is that clear? Mismatch repair defect causes hereditary non-polyposis colon cancer. And then about pyrimidine dimerization, as I told you, UV light causes pyrimidine dimerization. Whenever adjacent pyrimidines undergo dimerization, how do we repair it? We repair it by excising a nucleotide. Yeah, we repair it by excising a nucleotide. So the repair mechanism is called as nucleotide excision repair. And a defect of this nucleotide excision repair causes xeroderma pigmentosa. Yeah, what does it cause? It causes xeroderma pigmentosa. How will you remember it? Xeroderma has got an X. And this is caused by a defect of nucleotide excision repair mechanism. And then double-stranded DNA break repair mechanism. If there is a defect, it causes ABF disorders. So what is ABF? A stands for ataxia telangiectasia. Yeah, A stands for ataxia telangiectasia. B stands for Bloom syndrome. F stands for Fanconi's anemia. Okay, so double-stranded DNA break repair. Double-stranded DNA break repair defect causes ABF disorders. What is ABF disorder? Ataxia telangiectasia, Bloom syndrome and Fanconi's anemia. So can we summarize all that I've told you about DNA error and repair mechanism? Which is the most common error that happens in a DNA? It is base excision. And then mismatch repair defect causes defect causes CC. What is CC? Hereditary non-polyposis colon cancer. Pyrimidine dimerization happens in the presence of UV light, and that is repaired by nucleotide excision repair mechanism, and a defect of nucleotide excision repair causes xeroderma pigmentosa. Double-stranded DNA break repair defect causes ABF disorder, ataxia telangiectasia, Bloom syndrome and Fanconi's anemia. So what is the right answer for this question, all of you? This is a June 2021 FMGE question. The DNA repair defect that causes xeroderma pigmentosa is X, nucleotide excision repair. Now this is the next question. A 73-year-old woman presents with diffuse weakness and tingling sensation over her arms and legs. Okay, tingling sensation over her arms and legs. So neurological manifestations. A neurological examination reveals loss of vibration sense and position sense. So sensory system has been affected. So all of you are answering it as B12. Very good. There was also weakness in lower extremities. So what is that you observe here? Both sensory system and motor system have been affected. Yeah, both sensory and motor system are affected. So we call it as, what do we call it as? Anybody? Yeah, there is something called as combined degeneration, right? It is called as subacute combined degeneration. So why do we call it a subacute combined degeneration? Because both motor and sensory system has been affected here, and that is caused by B12 deficiency. Subacute combined degeneration is caused by vitamin B12 deficiency. So let's learn more about vitamin B12. What are the questions that can be asked about vitamin B12? Because in FMG there has been so many questions asked on this topic. So the first fact that you need to know about B12 is there are two coenzyme roles of B12. The first one starts with the first alphabet A. It is adenosyl B12. The second coenzyme form of B12 is methyl B12. Very good. It is more common in vegetarians, as Alia Khan has answered it. Vitamin B12 deficiency is more common among vegetarians because most of the sources of vitamin B12 are non-vegetarian. So these are the two coenzyme roles of B12. Now adenosyl B12 acts as a coenzyme for methylmalonyl-CoA mutase. Adenosyl B12 acts as a coenzyme for methylmalonyl-CoA mutase, whereas methyl B12 acts as a coenzyme for methionine synthase. What is the actual function of methionine synthase? It converts homocysteine to methionine. So what do you think is the other name for methionine synthase? It is otherwise called as homocysteine methyltransferase. Yeah, it is otherwise called as homocysteine methyltransferase. So these are the two coenzyme roles of B12. Why should you know about these coenzyme roles of B12? Only then you will be able to answer a case-based MCQ related to vitamin B12. So if methionine synthase is dependent on B12, if it is supposed to convert homocysteine to methionine, what do you expect whenever there is B12 deficiency? In B12 deficiency, methionine synthase will be inactive. So what accumulates? Homocysteine accumulates. So what is one of the manifestations of B12 deficiency? B12 deficiency presents as homocystinuria. Do you understand this? It presents as homocystinuria. And the next fact that you have to understand here is methyl B12 gets its methyl group from methyl tetrahydrofolate. Methyl B12 gets its methyl group from methyl tetrahydrofolate. So tell me what happens in B12 deficiency. In B12 deficiency, because methyl tetrahydrofolate will not be able to donate its methyl group, all tetrahydrofolate will be trapped as methyl tetrahydrofolate. Yeah, all tetrahydrofolate will be trapped as methyl tetrahydrofolate. So that causes folate deficiency. Okay, so what are the two manifestations of B12 deficiency that I've told you? Whenever there is B12 deficiency, homocysteine level increases, homocystinuria. And all tetrahydrofolate get trapped as methyl tetrahydrofolate. So this causes folate deficiency. And whenever there is folate deficiency, it causes macrocytic anemia. So B12 deficiency presents with homocystinuria. It also presents with macrocytic anemia. Now, what are the causes of macrocytic anemia, all of you? Macrocytic anemia can be either because of folate deficiency or it can be because of B12 deficiency. Okay, and when there is B12 deficiency, when adenosyl B12 is low, methylmalonyl-CoA mutase will be inactive. And when methylmalonyl-CoA mutase is inactive, methylmalonyl-CoA accumulates. What accumulates? Methylmalonyl-CoA accumulates. So this causes methylmalonic aciduria of B12 deficiency. Yeah, this causes methylmalonic aciduria of B12 deficiency. So if you suspect B12 deficiency, what will you estimate in urine? You estimate methylmalonic acid levels in urine, levels of which will be elevated. Okay, levels of which will be elevated. Yes, hypersegmented neutrophils are also observed in B12 deficiency. Because B12 deficiency causes folate deficiency, when there is folate deficiency, nucleus will not be able to divide. That is why you see hypersegmented neutrophils, wherein neutrophils have nuclei which are multiply segmented, they have not divided. Do you all understand this? So can we discuss about the manifestations? So what do you think are the manifestations of B12 deficiency? I'm going to write it down and I want all of you to answer it along with me. Keep the live chat box active, please. So B12 deficiency, what are the manifestations? The first manifestation is homocystinuria. Homocysteine levels will be elevated. Second manifestation is folate deficiency. And when there is folate deficiency, what will you expect? You expect macrocytic anemia. And in macrocytic anemia, as Alia Khan has mentioned, what did Alia Khan mention here? Hypersegmented neutrophils. Okay, hypersegmented neutrophils, because in the absence of folate, what cannot divide? Nucleus cannot divide. So you see hypersegmented neutrophils. And then methylmalonic acid accumulates. So what will you find? You will find methylmalonic aciduria in B12 deficiency. When methylmalonic acid accumulates, it goes and gets interfered. Yeah, it interferes with myelin synthesis and demyelination is observed. And this demyelination is the reason for all neurological manifestations. For example, if an elderly patient, yeah, forget about, yes, very good Bairam, you are excellent. So if an elderly patient comes to you and the patient says, I feel tingling sensation in my peripheries. Yeah, as a clinician, what you would do is you will give him or her a shot of B12. Have you seen elderly people receiving B12 injections regularly? Because B12 deficiency causes methylmalonic aciduria, and methylmalonic acid interferes with myelin. It causes demyelination and neurological manifestations. And that is why B12 deficiency presents with subacute combined degeneration. So what is the take-home message for all of you? The history. If the history says there is both motor defect and sensory defect, both motor and sensory defect, it means it is combined degeneration. If it is combined degeneration, you should think of B12 deficiency. What are the other manifestations of B12 deficiency? Homocystinuria, low folate levels, so macrocytic anemia, hypersegmented neutrophils, and neurological manifestations. And if you suspect B12 deficiency, you estimate methylmalonic acid level in the urine. Okay, I am telling you this repeatedly because this has been asked previously in FMGE. That is the next question for you all. Okay, so what is the answer for this? A 40-year-old male presents with shortness of breath while walking and climbing upstairs. Homocysteine level was elevated. Just now I told you a cause of homocysteine level elevation. What is the cause I told you, all of you? Yeah, homocysteine level getting elevated. One of the causes is B12 deficiency. Yes, very good Alia Khan and Ghost Rider. You are saying it is B12. But look at the next statement. What is the next statement? Methylmalonyl-CoA levels was normal. If methylmalonyl-CoA level is normal, can it be B12 deficiency? No. Had it been B12 deficiency, methylmalonic acid levels should have been high. So you are excluding B12 deficiency with this. So what is the next choice? Yeah, it is not folate deficiency also. What is the answer? It is B6 deficiency. Yeah, what is it? It is B6 deficiency can also cause homocystinuria. Okay, so it is not folate deficiency, all of you. The answer is homocystinuria is caused by B6 deficiency. You will understand it better if you know normal homocysteine metabolism. So hang on with me for a few minutes. I will tell you the normal homocysteine metabolism, and then I will tell you the causes of homocystinuria, and then I will tell you how to find out the exact cause of homocystinuria based on the history that is provided to you. Okay, so what are the two fates of homocysteine? Homocysteine, a sulfur containing amino acid, can get converted to one or the other sulfur containing amino acids. So tell me, what are the two sulfur containing amino acids in your body? One is cysteine, the other one is methionine. So the homocysteine that is in your body gets either converted to cysteine or it gets converted to methionine. How will homocysteine get converted to cysteine? Homocysteine reacts with serine in the presence of cystathionin beta synthase. All of you keep repeating along with me from wherever you are. So what is the enzyme? It is cystathionin beta synthase, which allows homocysteine to react with serine to form cystathionin. Now this cystathionin in the presence of cystathioninase gets converted to cysteine. Yeah, cystathionin in the presence of cystathioninase gets converted to cysteine. And this cystathionin beta synthase is dependent on B6. Okay, that is dependent on B6. So this is one fate of homocysteine. What is the other fate of homocysteine? Homocysteine can get converted to methionine. So which enzyme converts homocysteine to methionine? This is what I told you in the previous question. Logical name for this enzyme should be methionine synthase. Yeah, logical name for this enzyme will be methionine synthase. It is otherwise called as homocysteine methyltransferase. And this enzyme needs what acids coenzyme? This enzyme needs methyl B12 acids coenzyme. Just now I told you methyl B12. From where does methyl B12 get its methyl group? From methyl tetrahydrofolate. Okay, now tell me, what are the causes of homocystinuria? Homocystinuria will be caused by a defect of either the major root or the minor root. So homocystinuria is caused by either B6 deficiency. It is caused by either B6 deficiency or by B12 deficiency. So how will you find out whether it is B6 deficiency or B12 deficiency? Because if it is B12 deficiency, methylmalonic acid levels will be elevated. So you look for methylmalonic acid level. If that is elevated along with homocysteine level being elevated, then that is B12 deficiency. But if there is only an elevation of homocysteine but methylmalonic acid level is normal, then it is B6 deficiency. Do you all understand this? So tell me, what are the two causes? As far as vitamin deficiency is concerned, there are two causes for homocystinuria. One is B12 deficiency, the other one is B6 deficiency. To differentiate the two, you estimate methylmalonic acid levels. If methylmalonic acid level is also elevated, it is B12 deficiency. But if that is normal, it is B6 deficiency. Do you all understand this? Now tell me the answer. There is an elevation of homocysteine, but methylmalonic acid level is normal. So this is not B12. What is the right answer? The right answer is B6. Okay, so now do you all understand how conceptually you have to learn the subject? Yeah, this is not a question that I made up. This is a previous year FMGE question, June 2021 question. Look at the complexity of the question. Yeah, so I've seen many FMGE aspirants saying I'm only when I say only, it is a clearance exam. Because it's a clearance exam, students tend to think that I don't have to know everything in deep. I'm going to learn only facts. I'm going to clear the exam. Yeah, that is why many of the FMG aspirants fail, because they learn it superficially. I want you to learn everything conceptually in a deep way. Only then you will be able to answer case-based MCQs. Okay. Now somebody was asking me about, what did you ask about? You asked about vitamin deficiency, thiamine deficiency in chronic alcoholism. So with this question, I will explain you that a person has a history of alcoholism for 20 years. He avoids alcohol for 2 days. Very good, Alia. Alia is rocking, as I told you previously. Yes, the answer is delirium tremens. Okay, so let us look at the history. There is a person who is a chronic alcoholic. He has avoided alcohol for 2 days, and the person is presented with agitation, global confusion, disorientation, and hallucination. Fever, high BP, diaphoresis, and autonomic hyperactivity. The most common causes. What is the answer? So do you see that there are not only mental symptoms? What do you mean by mental symptoms? Agitation, global confusion, disorientation, hallucination. All these are mental symptoms. But along with that, there are also physical symptoms like fever, high BP, diaphoresis, and autonomic hyperactivity. If you see both existing together, go for delirium tremens. Also, there is a history of alcohol withdrawal. So delirium tremens is a manifestation of alcohol withdrawal, and that is why I am choosing it as choice A. But I am going to help you exclude other choices. Yeah, the first choice that I want to exclude is Wernicke's encephalopathy. What is Wernicke's encephalopathy? Alia Khan has answered it as Goa. Bairam has also answered it as Goa. So what is Wernicke's encephalopathy? This is acute thiamine deficiency. What is it? It is acute thiamine deficiency that is observed in a chronic alcoholic. So one of you had asked me why chronic alcoholism presents with thiamine deficiency. Why? Because alcohol, how is alcohol metabolized? Alcohol is RCH2OH that is metabolized by alcohol dehydrogenase, which converts it into an aldehyde. And this aldehyde is metabolized by aldehyde dehydrogenase, which becomes an acid. Yeah, it becomes an acid. So every dehydrogenase, be it alcohol dehydrogenase or aldehyde dehydrogenase, whenever they act, they synthesize NADH. So metabolic status of a chronic alcoholic, anybody who consumes alcohol, yeah, what is the metabolic status? There is a high NADH-NAD ratio. This was asked once in FMGE. Yeah, what is the metabolic status of a chronic alcoholic? It is high NADH-NAD ratio. And this high NADH-NAD ratio will be translated as high ATP-ADP ratio. So there is high energy. Anybody who consumes alcohol is in a high energy status. And until there is high energy, will the person feel hungry? All of you answer this in the chat box. Until the energy status is high, will the person feel hungry? No. So a chronic alcoholic often misses balanced diet. And balanced diet is supposed to provide a person with essential micronutrients. So there will be micronutrient deficiencies. Yeah, there will be micronutrient deficiencies, and the most common micronutrient to become deficient in a chronic alcoholic will be thiamine. Why thiamine deficiency is very common in a chronic alcoholic? One reason is high energy status, so the person does not have the mixed balanced diet. That is one reason. The other reason is, even if the person takes the mixed balanced diet, because alcohol interferes with thiamine absorption as well. Yeah, it is not only because the person misses mixed balanced diet, because alcohol interferes with thiamine absorption. There is thiamine deficiency, which is very common. Third reason for thiamine deficiency in a chronic alcoholic is alcohol interferes with magnesium absorption. Alcohol interferes with magnesium absorption. What if there is magnesium absorption? What is the coenzyme role of thiamine? In which form is thiamine? Mohammed Jafar asked. Thank you, Mohammed Jafar, for such a good question. So what was I asking you? I was asking you what is the coenzyme role of thiamine? It is thiamine pyrophosphate. So how do you convert thiamine into thiamine pyrophosphate? That is done by thiamine kinases. And these kinases are dependent on magnesium. Yeah, these thiamine kinases are dependent on magnesium. So chronic alcoholic, magnesium is not absorbed. When magnesium is not absorbed, thiamine kinase is inactive. So thiamine cannot be converted to the active form of thiamine. So these three are the reasons for thiamine deficiency in a chronic alcoholic. What are the three reasons? Alcohol is a high energy status. The person misses mixed balanced diet. So all micronutrients will be deficient. Alcohol interferes with thiamine absorption. Alcohol interferes with magnesium absorption. Okay, so that's about alcohol and thiamine deficiency. And whenever there is thiamine deficiency in an alcoholic, it can present in two ways. One is acute thiamine deficiency. The other one is chronic thiamine deficiency. Acute thiamine deficiency is otherwise called as Wernicke's encephalopathy. What is it otherwise called as? Wernicke's encephalopathy. And how do we remember the manifestations of Wernicke's encephalopathy? As Alia Khan and I think Byram. Yeah, Alia Khan and Byram had answered it. You can have a mnemonic for it. The mnemonic is GOVA. So what does GOVA stand for? Capital G stands for global confusion. O stands for ophthalmoplegia. A stands for ataxia. So the history clearly states there is a chronic alcoholic who is presenting with global confusion, ophthalmoplegia and ataxia. What will be your answer? Your answer will be acute thiamine deficiency or Wernicke's encephalopathy. Chronic thiamine deficiency will present as Korsakoff syndrome. Yeah, chronic thiamine deficiency, chronic Korsakoff. They sound similar, right? So chronic thiamine deficiency will present as Korsakoff syndrome, and Korsakoff syndrome will present with memory loss. In acute deficiency, there is just confusion. In chronic thiamine deficiency, complete memory loss. So what will you find? You will find retrograde amnesia, anterograde amnesia. And when there is memory loss, to fill up the memory gaps, they start fabricating stories. Yeah, fabrication of story is called as confabulation. Did you all see that question in, I think it was asked in December 2021. FMGE December 2021, there was a history which stated there is a person who is a chronic alcoholic presenting with confabulation, fabricating stories. What is your diagnosis? Very good, Byram. What is your diagnosis? Confabulation. It is chronic thiamine deficiency or Korsakoff syndrome. Okay. So have you understood all about alcoholism and thiamine deficiency? Yeah, Jafar. So tell me, can it be Wernicke's encephalopathy? This is not Wernicke's encephalopathy. Why is it not Wernicke's encephalopathy? Because that does not only present with global confusion, there should also be ophthalmoplegia and ataxia. They have not mentioned anything about ophthalmoplegia and ataxia, but what have they mentioned about? They have mentioned about high blood pressure, high heart rate, fever, and all those are never observed in Wernicke's encephalopathy. Okay. Now, can it be Korsakoff syndrome? What does Korsakoff syndrome present with? I told you just now. I said it is memory loss, retrograde and anterograde memory loss and confabulation. Okay, so this is not Korsakoff syndrome. We know for sure it is not pancreatitis. Pancreatitis is not going to present with hallucination, disorientation or confusion. So what are you left with? You are left with delirium tremens. And what are the facts that you need to know about delirium tremens? It's a feature of alcohol withdrawal. Yeah, it is present between, it presents itself between 2nd and the 10th day of alcohol withdrawal, more common on the 2nd day. And what does it present with? It presents with GHN. Yeah, GHN. Yeah, you can remember it as government hospital nurse. That's how I remember it. Yeah, GHN. G stands for global confusion. H stands for hallucination. N stands for nightmares. So what are the manifestations of delirium tremens? GHN. What does GHN stand for? Global confusion, hallucination and nightmares. And these are mental symptoms. What are the physical symptoms that you observe in delirium tremens? They present with high blood pressure, high heart rate, high body temperature. That can be sweating, that can be tremors. That is why it is called as tremens. Okay. So it presents with high body temperature, high blood pressure, high heart rate, shaking, tremors. Okay. So the right answer here is delirium tremens. So this is the question that I was telling you just now. A chronic alcoholic presents with generalized weakness and lethargy. He was making up stories. What do you call it as? Making up stories is nothing but confabulation. So what is it because of? The probable vitamin deficiency. So do you see that there is nystagmus and ataxia also? So there is a mix-up of both acute thiamine deficiency manifestations and chronic thiamine deficiency manifestations. So your answer is going to be thiamine. Okay, is it not simple now? Now this is the next question that I wanted to discuss. Which of the following enzyme defects causes von Gierke's disease? Glycogen storage disorder is a favorite topic of FMGE. Yes, von Gierke's disease is caused by the defect of, yes, Nigar Ansari. Not only you, many make a mistake here. Many tend to answer it as glucose 6-phosphate dehydrogenase in spite of the fact that they know very well that it is caused by a defect of glucose 6-phosphatase. Yeah, please don't get confused between the two names. Very good, Alia Khan. Yes, it presents with doll-like faces. So von Gierke's disease is caused by a defect of glucose 6-phosphatase. I want all of you to be very clear. Glucose 6-phosphatase is completely different from glucose 6-phosphate dehydrogenase, because glucose 6-phosphate dehydrogenase is an enzyme of which pathway? It's an enzyme of HMP shunt. And if this enzyme is defective, what does it present as? It does not present with hypoglycemia. What does it present with? It presents as hemolytic anemia. Very good, Byram. You're rocking it. Yes. What? Very good, Alia Khan. Yes. What will it present as? It will present as hemolytic anemia following exposure to oxidative stress. So those of you who are watching this session, if the history states there is a child who was growing up normally, suddenly presents with hemolytic anemia following exposure to primaquine. What is primaquine? It's a prophylactic drug given for malaria that induces oxidative stress. So hemolytic anemia following exposure to oxidative stress, what will be our answer? It is G6PD deficiency, glucose 6-phosphate dehydrogenase deficiency, and enzyme of HMP shunt. Okay. Whereas if it is as hypoglycemia, a neonate presenting with hypoglycemia, what will be your diagnosis? Your diagnosis will be von Gierke's disease, which is caused by the defect of glucose 6-phosphatase. Glucose 6-phosphatase is an enzyme of glycogenolysis and gluconeogenesis. Yeah, glucose 6-phosphatase is an enzyme of glycogenolysis and gluconeogenesis. When both the pathways are defective, these are the two pathways which can maintain blood glucose. When both these pathways are defective, what will it present as? It will present as hypoglycemia. Okay, now we are going to fill up this tabular column. So what is this tabular column about? This tabular column is about all the 7 glycogen storage disorders which are frequently asked. So I am going to tell you the name of all these defects, and I will be telling you about the enzyme defects which cause those disorders. Okay, let's start with type 1. What is type 1? Very good, Byram. Very good, Alia Khan. Can all of you answer, please? So type 1 is von. Yeah, 1 is von Gierke's disease. And von Gierke's disease is caused by the defect of, just now we discussed, glucose 6-phosphatase enzyme. Okay. Type 2, it is Pompey's disease. Type 2 is Pompey's disease, which is caused by the defect of acid maltase. Okay, acid maltase, otherwise called as alpha glucosidase. At this point, I want all of you to remember one fact. Yeah, the fact is alpha glucosidase defect and beta glucosidase defect. Whenever you learn a fact, please compare and contrast similar facts and learn. Okay, only then you will not get confused during the exam. So what should you know about alpha glucosidase and beta glucosidase? Alpha glucosidase defect causes Pompey's disease. Okay, beta glucosidase defect causes the famous Gaucher's disease. Can you all memorize it? Alpha glucosidase defect causes Pompey's disease. Beta glucosidase defect causes Gaucher's disease. So going back to glycogen storage disorders, type 2 glycogen storage disorder is Pompey's disease caused by the defect of acid maltase or alpha glucosidase. Okay, yes. Gaucher's is characterized by crumpled tissue paper appearance. You're right. Now type 3, which is the third alphabet, all of you? Which is the third alphabet? C. So type 3 is C, Cory's disease. Yeah, type 3 is C, Cory's disease caused by the defect of, after C, the alphabet is D. So D stands for D-branching enzyme. Okay, D stands for D-branching enzyme. So type 3 is Cory's disease caused by the defect of D-branching enzyme. What is type 4? So type 3 is CD, type 4 is AB. What does AB stand for? Type 4 is Anderson's disease. Okay, type 4 is Anderson's disease caused by the defect of branching enzyme. Now type 5, yeah, it is reverse 5, Roman letter 5. If you reverse and write it twice, it is M, right? So what is it? It is McArdle's. Type 5 is McArdle's disease. It is caused by the defect of muscle phosphorylase. M for M, McArdle is caused by the defect of muscle phosphorylase. Type 6 is Hers disease. Okay, type 6 is Hers. H for H, hepatic phosphorylase defect. Hers disease is caused by the defect of hepatic phosphorylase or liver phosphorylase enzyme. Finally is type 7. What is type 7? It is Taruvus disease. Type 7 is Taruvus disease. Very good, Alia Khan. It is caused by the defect of phosphofructokinase 1, the rate limiting enzyme of glycolysis. Okay, type 7 Taruvus is caused by the defect of phosphofructokinase 1, the rate limiting enzyme of glycolysis. So can you repeat all that I've told you so far? Yeah, quickly have a look at this. This visual memory will help you. So look at the tabular column. Type 1 von Gierke's disease is glucose 6-phosphatase defect, which is an enzyme of glycogenolysis and gluconeogenesis. When both these enzymes are defective, it is going to present as hypoglycemia. Type 2 is Pompey's disease caused by the defect of acid maltase. What is it otherwise called as? Acid maltase is otherwise called as alpha glucosidase. Beta glucosidase defect causes Gaucher's disease, characterized by tissue paper appearance, crumpled tissue paper appearance, because of macrophages accumulating the lipids. Okay. Type 3, third alphabet is C. So type 3 is Cory's disease caused by the defect of debranching enzyme. Type 4 is AB, Anderson, caused by the defect of branching enzyme. Type 5, McArdle's muscle phosphorylase defect. Type 6, Hers is hepatic phosphorylase defect. Type 7 is Taruvus disease, which is caused by the defect of phosphofructokinase 1, the rate limiting enzyme of glycolysis. So what is the right answer here? Which of the following enzyme defects causes von Gierke's disease? Your answer should be glucose 6-phosphatase. This is a neat PG question, but because it's a vitamin based session, I've included it here. Okay, so a known patient of tuberculosis on isoniazid for 6 months presents with tingling sensation, paresthesia. It's very simple. They are asking you isoniazid presenting with neurological manifestations. Okay, deficiency of which of the following vitamins is the most common cause? Deficiency of which of the following vitamins is the most probable cause? What is the right answer? Very good, all of you. Yes, it is B6. Vitamin B6 deficiency. So why should isoniazid present with B6 deficiency? It is because isoniazid is an aldehyde. Yeah, it is an aldehyde and it's a structural analog of pyridoxal. Pyridoxal is also an aldehyde. So instead of pyridoxal being acted upon by pyridoxal kinase, your isoniazid is a competitive inhibitor. So isoniazid is a structural analog of pyridoxal. So instead of pyridoxal being acted upon by pyridoxal phosphate, your INH goes and competitively inhibits pyridoxal kinase. And that causes B6 deficiency and that causes neurological manifestations. Okay. Which of the following vitamin deficiency causes the condition shown in the image? So many image based questions are asked in FMGE. What is the image that is provided to you here? Yeah, this is Bitot spots. You see a foamy white color patch on the patch on the conjunctiva, right? So what is it? It is Bitot spot. It is caused by vitamin A deficiency. So it's a very simple question. Bitot spots caused by vitamin A deficiency, but I'm going to use this opportunity to tell you more about vitamin A. Yeah, few facts about vitamin A which can be asked as an MCQ in your exam. So first tell me, what are the 3 vitamin A forms? What are the 3 forms of vitamin A? Retinol, alcohol form retinol, aldehyde form retinal, and the acid form retinoic acid. So these are the 3 forms of vitamin A. And the first form, retinol, the significance of this form is, this is the form in which vitamin A is absorbed. This is the form in which vitamin A is transported and stored. So if the question is which form of vitamin A is absorbed, transported and stored, what will be your answer? It's the alcohol form retinol. The aldehyde form retinal is present in the eye. How do we remember it that this is the form that is present in the eye? Do you see retina here? In retinal name, you see retina. So use it to remember that this is the form that is present in the eye. So eye, you have rods and cones. And rods and cones have rhodopsin. Yeah, they have rhodopsin. What is rhodopsin? It is nothing but 11-cis retinal. Until rhodopsin is stimulated by light, it is nothing but 11-cis retinal plus opsin. Okay. Now retinoic acid, there are two forms of retinoic acid. One is all trans retinoic acid. The other one is 13-cis retinoic acid. All trans retinoic acid helps in growth and differentiation of epithelium, whereas 13-cis retinoic acid helps in suppressing keratinization of epithelium. So tell me, what is the role of 13-cis retinoic acid? It suppresses keratinization of epithelium. So just imagine, just visualize and tell me what will happen in vitamin A deficiency. Whenever there is vitamin A deficiency, there is low 13-cis retinoic acid, no suppression of keratinization. So all epithelium will undergo keratinization. And this excess keratinization is the reason for phrenoderma. Have you all heard of phrenoderma? Small bumpy lesions which are seen on the extensor surfaces of your limb. Yeah, small bumpy lesions seen on the extensor surfaces of your limb is phrenoderma. This is otherwise called as follicular hyperkeratosis. Phrenoderma is nothing but follicular hyperkeratosis. So hyperkeratosis means keratotic lesions caused by vitamin A deficiency. Yeah, and the second thing that you should remember here is whenever there is hyperkeratinization of conjunctival epithelium, that causes conjunctival xerosis. And it accumulates as Bitot spots. Yeah, it accumulates as Bitot spots. And then I should also tell you about another application of 13-cis retinoic acid. Only because it suppresses keratinization of epithelium, we give 13-cis retinoic acid for any hyperkeratotic condition. Yeah, any hyperkeratotic condition, what can you give? 13-cis retinoic acid, because it suppresses keratinization of epithelium. So that's all about vitamin A. What are the three forms of vitamin A? The alcohol form retinol is the form in which it is absorbed, transported and stored. The aldehyde form of vitamin A, retinol, is the form that is present in rods and cones in the form of rhodopsin. Retinoic acid, we have all trans retinoic acid and 13-cis retinoic acid. All trans retinoic acid helps in growth and differentiation of epithelium. 13-cis retinoic acid suppresses keratinization of epithelium. That is why vitamin A deficiency presents with phrenoderma, xerosis, conjunctival xerosis and Bitot spots. Okay. Yeah, what is the right answer here? Which of the following enzyme activities can be estimated in RBCs to diagnose riboflavin deficiency? Very good, Byram. Very good, Ansari. Very good, Alia. So riboflavin, vitamin B2 is riboflavin deficiency can be assessed by measuring RBC glutathione reductase activity. Yeah, RBC glutathione reductase activity. How do we remember it? Riboflavin, ribbon and glue go hand in hand. Yes or no? Yeah, can you see that image here? Ribbon and glue go hand in hand as far as artwork is concerned. So ribbon, riboflavin deficiency, glue, glutathione reductase activity. Yeah, glue, glutathione reductase activity. Very good. Yes. So thiamine deficiency or vitamin B1 deficiency. Yeah, for B1 deficiency, what will you estimate? You will estimate RBC transketolase activity. It is RBC's transketolase activity. So now I am going to fill up this tabular column, wherein I am going to tell you what are the investigations that can be done to detect various vitamin deficiencies. Yeah, so you are going to help me fill up this tabular column. Let's start with vitamin B6. B6 ends with which letter? 6 ends with which letter? X. So what is the investigation that you will do? X stands for xanthurenic acid. Yeah, X stands for xanthurenic acid. So if you suspect vitamin B6 deficiency, you estimate xanthurenic acid. After X, what is the alphabet? After X, it is Y. So you estimate xanthurenic acid levels after tryptophan load. Yeah, after tryptophan load. It's easy, right? Yes, homocysteine levels are also elevated Viram in B6 deficiency, but there are so many other causes of homocystinuria. So it's not very specific for B6 deficiency. So whenever you do an investigation to detect a vitamin deficiency, it should be very specific. So for vitamin B6, what is that you estimate? Xanthurenic acid levels are estimated in urine after tryptophan load. And if you suspect folate deficiency, folate starts with which letter? Folate starts with F. Okay, so what will you estimate in urine? You estimate F Figlu. Yeah, if you suspect folate deficiency, what will you estimate in urine? You estimate Figlu levels in urine. After F and G, it is H. Yeah, after F and G, it is H. So after what load do you do that? It is histidine load. After a histidine load, you estimate Figlu levels if you suspect folate deficiency. Now, can you answer this? If you suspect B12 deficiency, what will you estimate? For B12 deficiency, didn't I tell you methylmalonic acid levels should be estimated in urine after an overnight fast? Okay, only when you fast a person, there will be fatty acid oxidation. Only when there is fatty acid oxidation, methylmalonic acid levels will be elevated. Okay, so can we fill up this tabular column again? So tell me, what are the vitamin deficiencies I've told you about? I'm summarizing about all vitamin deficiencies. Please answer this. So if you suspect B1 deficiency, what will you estimate? B1 deficiency, it is RBC transketolase activity. If you suspect B2 deficiency, B2 is riboflavin, right? Yeah, it is riboflavin, ribbon and glue. So what will you estimate? RBC glutathione reductase activity. If you suspect B6 deficiency, 6 ends with which letter? X. So what will you estimate in urine? X stands for xanthurenic acid levels have to be estimated in urine. After what load? After tryptophan load test. If you suspect folate deficiency, what will you estimate in urine? F for F. You estimate Figlu levels in urine. FG. This is done after what load? Histidine load. Okay. If you suspect B12 deficiency, what will you estimate? Methylmalonic acid level should be estimated after what? Overnight fast. Okay, so that's about vitamin deficiencies and investigations. A woman on antidepressant presents with bleeding. She gives a history of bulky stools which stick to the pan. Okay, bulky stool sticking to the pan. What is your diagnosis? Bulky stool sticking to the pan will be steatorrhea. And following steatorrhea, a person is presenting with bleeding. So some malabsorption, fat malabsorption is presenting with bleeding. So all fat soluble vitamins will be deficient in this person. Which fat soluble vitamin deficiency will cause bleeding? Yeah, it is vitamin K deficiency. So what is the right answer? So steatorrhea presenting with bleeding should be vitamin K deficiency. Okay, so a few facts I want you to know about vitamin K. You don't have to know the intricate details of the structure, but I want you to know that this is the structure of vitamin K. It has got a complex naphthoquinone ring which is attached to a side chain. Yeah, it is attached to a side chain, and this side chain is responsible for the non-polar nature of vitamin K. Yeah, the side chain is responsible for the non-polar nature of vitamin K. And if the side chain length is 20 carbon atoms, you call it as vitamin K1. If the length is 30 carbon atoms, you call it as vitamin K2. And if the side chain, there is no side chain, if that is replaced by hydrogen, if there is no side chain, if that is replaced by hydrogen, that is called as menadione. So what is the clinical significance of menadione? If a fat malabsorption syndrome, a patient presenting with fat malabsorption syndrome or steatorrhea is also presenting with bleeding, we know it is because of vitamin K malabsorption. So you should give a form of vitamin K which is not dependent on fat digestion and absorption. So what will you give? You give menadione, because menadione is polar. It gets easily absorbed into circulation. So steatorrhea presenting with bleeding, what will be your treatment? Your treatment will be menadione, which is polar, which gets easily absorbed. Okay. Which is the marker enzyme for microsomes? Very good, Alia Khan. Which is the marker enzyme for microsomes? Pick the right answer. Can it be galactosyl transferase, cathepsins, lactate dehydrogenase, or glucose 6-phosphatase? Can we start excluding choices one by one? Yeah, it is not galactosyl transferase, because galactosyl transferase is related to glycoprotein synthesis. And where is glycoprotein synthesized? It is synthesized in Golgi complex. So which is the enzyme marker for Golgi complex? It is galactosyl transferase. It's easy to remember, right? Which is the enzyme marker for Golgi complex? It is galactosyl transferase. Now cathepsin, this is not cathepsin, because cathepsin is present in lysosome. So lysosomal enzyme marker is cathepsin. Can it be lactate dehydrogenase? First tell me which pathway is lactate dehydrogenase related to. Lactate dehydrogenase is an enzyme of glycolysis. Where does glycolysis happen? It happens in cytoplasm. So lactate dehydrogenase is an enzyme of cytoplasm, enzyme marker for cytoplasm. So which is the right answer? By exclusion, the marker enzyme for microsome is glucose 6-phosphatase. First tell me what is a microsome. Microsome is nothing but endoplasmic reticulum. Do you understand this? Whenever you homogenize a tissue, the endoplasmic reticulum will be broken down to give rise to microsome. And the enzyme marker for microsome is glucose 6-phosphatase, which is an enzyme of, as I told you, glycogenolysis and gluconeogenesis. Okay, so again, we are going to fill up this tabular column which tells you about the marker enzyme for every suborganelle. Let's start with nucleus. Which is the enzyme marker for nucleus? I hope you all know that nucleus is related to replication and transcription. And which enzyme is related to replication and transcription? It is DNA polymerase or RNA polymerase. Okay, so it's either DNA or RNA polymerase, which is the enzyme marker for nucleus. For endoplasmic reticulum, just now I told you endoplasmic reticulum marker or microsomal marker is endoplasmic reticulum marker or microsomal marker is glucose 6-phosphatase, an enzyme of glycogenolysis and gluconeogenesis. Very good. Golgi complex is related to glycoprotein synthesis. To synthesize glycoprotein, what is that we need? We need galactosyl transferase. Now mitochondrial outer membrane. Can I write outer membrane as OM? Yeah, outer membrane is OM. And the enzyme is MAO. What is MAO? Monoamino oxidase. For outer membrane, it is monoamino oxidase. For inner membrane, what is the enzyme marker? I hope you all know that electron transport chain is present along the inner side of inner mitochondrial membrane. So inner membrane marker should be one of the parts of electron transport chain. Which part of electron transport chain is it? It is ATP synthase. Very good, Byram. Yes, it is ATP synthase, which is the enzyme marker for inner membrane. For lysosome, just now I told you it is cathepsins. Cathepsins are proteases which are present within lysosome, which are their enzyme markers. Cytoplasm, remember glycolysis happens in cytoplasm and the glycolytic enzyme is lactate dehydrogenase. Very good. Now what about peroxisome? The name peroxisome tells you that it generates lots of hydrogen peroxide, right? The name peroxisome by itself tells you that generates lots of hydrogen peroxide. So the enzyme catalase, catalase detoxifies hydrogen peroxide that is present in excess quantities in peroxisome. So which is the enzyme marker for peroxisome? It is catalase. Okay, is it clear? So for nucleus, it is DNA or RNA polymerase. For endoplasmic reticulum, it is glucose 6-phosphatase. For Golgi complex, G for G, it is galactosyl transferase. For mitochondrial outer membrane, it is monoamino oxidase. For inner membrane, it is ATP synthase. For lysosome, it is cathepsins. For cytoplasm, it is lactate dehydrogenase. For peroxisome, it is catalase. Okay. So that's all for now. Do join the 2 p.m. session. That will be part 2 of the same marathon. And in part 2, I will be discussing about few metabolic pathways and few genetic questions, yeah, which have been asked previously. Previous year questions of FMGE will be discussed. Okay. So thank you. See you all at 2 o'clock. My pleasure, Ravi. Bye, Alia.